This program is intended to be general in nature and should not be used as a substitute for advice from a qualified health provider.
On Health Matters Television for Life. Feeling sad or maybe anxious? Lots of people struggle with mental illness, but finding care isn't always easy. A new approach is changing that.
RISE is an intensive day treatment program. Get the skills and the help that you need, and then get back out into your daily life.
Learn why this kind of treatment is just what teens and adults are looking for. All that and your questions answered live, right now on Health Matters.
Health Matters is made possible by our viewers, the friends of KSPS, and by Providence Healthcare.
I'm Arnie Peterson, and I'm an orthopedic surgeon, and I work at Sacred Heart for Providence Medical Group. When I needed my hip replaced, I chose Providence because of the professionalism and the care that I knew I'd receive. I never thought twice about going anywhere else.
My name is Beth Perez, and I am a registered nurse, and I work at Holy Family Hospital on the labor and delivery unit. I'm about to have my second child, and I chose Providence because I love and trust the people that I work with, and why wouldn't I seek care from people that I love and trust?
Good evening, I'm Teresa Lukens, and welcome to another season of Health Matters. Everyone has a bad day now and then, but when do the blues signal something that needs medical attention? Depression is diagnosed in 3 million people every year in the United States. Tonight, we're going to take a closer look at that, plus the sometimes paralyzing effects of anxiety. Here to share their expertise, our panel. Kim Chupurdia is a psychologist with MultiCare Rockwood. She works in the Behavioral Health Center. Katie Anderson is a licensed mental health counselor and family therapist for Providence Healthcare. Dr. Justin Garrett specializes in psychiatry. He works at Kootenai Health. Dr. Erik Loraas is a child and adolescent psychiatrist. He works at Providence Healthcare's RISE program. He is also part of the Spokane Psychiatry Residency program. And a reminder that we are streaming this program live on Facebook if you're not able to see us here on KSPS. And we do welcome your phone calls and emails as we continue our discussion tonight on depression and anxiety. So panel, let's first start with defining the topic tonight of depression and anxiety. Dr. Garrett, depression, what are we talking about?
Well, when we're thinking about depression in psychiatry, we're not thinking about just sadness or having a bad day. We're thinking of a diagnosis called major depressive disorder, sometimes called clinical depression. That is a prolonged period of low mood with accompanying symptoms including problems with poor sleep, feelings of worthlessness, hopelessness, low energy, poor concentration, impaired appetite, and when it gets more severe, thoughts about wanting to be dead or thoughts about suicide.
And I would guess these are long-term thoughts and feelings that people are having, not short-term, say I'm having a bad day, like we mentioned in the introduction.
Right, so this wouldn't just be I'm having a bad day because work was tough or I'm having difficult interpersonal problems. Those might be stressors that contribute to a major depressive episode, but when we're going to diagnose major depressive disorder, it's something that's gone on for at least 2 weeks or longer. But in most of our patients, it's extended even beyond that.
Mm-hmm. And what about anxiety? Katie, how does that manifest, and is it related to depression?
Well, we often see an overlap between depression and anxiety. They can co-occur together. Anxiety usually means a pervasive and out of the ordinary amount of fear or worry that impedes our ability to function on a daily basis and often accompanies some kind of avoidance behavior as well. The thing that I am afraid of, I avoid it, which then teaches me by avoiding it, I no longer am afraid, which then continues the cycle of avoiding whatever it is that's causing that fear. So they absolutely can coincide together.
Mm-hmm. So let's break this down because it can be different depending on what age you're at, for children, for instance, or the elderly, about the signs and symptoms of depression. First with kids.
Mm-hmm. So in many ways it does present similar to adults, but I think one of the big differences is what we call externalized behavior, so behavior that's expressed outward. And children and adolescents tend to show more irritability, maybe more tantrums or acting out more at home. But at the same time, they may withdraw more. So spend more time in the room, spend less time with friends, spend less time with family, less engagement in previously enjoyed activities. So not wanting to go out to the sport team or no longer wanting to play in the band. So things like that can really show up. But other issues of feeling hopeless, feelings of guilt, poor concentration, and then in extreme cases, not wanting to be alive are also present in children and adolescents.
Do they even understand what's happening? Can they, or will parents or caregivers be more likely to recognize those symptoms?
So I think for very young kids, so I'm talking 5, 6, 7, oftentimes it's going to be what's appreciated by teachers, parents, the adults in their lives. But I always say kids are remarkable in kind of how well they know themselves, and I'd say at 7 or 8, they're easy to say just something's not right. Will they be able to say this is depression? Maybe not. But they know themselves well enough to say something's off.
And what about young adults?
With depression? It's not terribly different from everything that's been said before. I think the irritability piece tends to be just more with younger kids and teens, and that tends to phase out by the time you get into adulthood and see more of the blue, sad, mopey.
Are there different triggers, so to speak?
Well, there certainly is a lot of different stressors as you move into adulthood. You know, it's not unusual to see kids who are just out of college, I'm calling them kids, having to deal with finances and buying a car or getting married, and all the real life stressors that start to hit in can be very difficult and certainly trigger a depressive episode, especially if they've had one before.
And then in the elderly, life changes, losing a spouse, can that all play in as well and manifest differently as we age?
Certainly loss of function, worsening medical illness, retirement and lack of things to do during the day. All of these things can contribute and be stressors. So some people will get depressed at times when there are no clearly identified stressors, but oftentimes there are definitely major stressors that we can find when we interview the patient.
Well, and that brings us to the diagnosis. A parent or a person themselves may start to recognize that they are depressed, and then they seek out help, or hopefully seek out help. And then what?
Well, it would often come to light with a person presenting to their family doctor or seeking out a counselor on their own. We see a lot of variability in patients. Some people are much more aware of themselves psychologically, and they recognize stressors building in their lives. They see that their functional level is decreasing. They're not sleeping as well. They're not eating as well. Their energy level is lower. They're feeling more depressed, and they seek out help. And sometimes we'll have patients like the hardworking guy whose wife notices he's just not doing as well as he used to since he retired or got laid off work, or since whatever stressor has happened in his life. And then the family member is urging them to get into treatment or get into to see someone for evaluation. So most people are being seen by a primary care physician or a PA or nurse practitioner for their initial contact with the healthcare system for diagnosis. And at that point, there would end up being, once a diagnosis of a major depressive disorder is made, consideration for what type of treatment would be pursued, medication options versus referral to counseling or psychotherapy.
And this isn't, we're not talking about, depression isn't one particular depression. There are different types of depression, are there not? And how do we break those down, especially during a diagnosis?
Well, I think the person most qualified for diagnostic testing would be either the psychologist or the psychiatrist in the room. I step in when therapy comes into play.
Okay. Kim?
Well, diagnostically, there are just different factors that are involved in each depression, and length of time can become a factor as well. You can have a long, more low-grade, persistent depression that lasts, up to a year or two, versus a major depressive episode, which could be less in terms of time length. Then there are also bipolar depressions, which are a whole nother ball of wax that involve a depressed mood as well as another type of mood disorder in there too, a manic episode. So we just ask a lot of questions and look over the course of your life and how it's impacting your functioning to get a feel for what's going on day to day so we can make a good treatment plan.
So the next step then, is it often a team approach then, as we often see now in the medical field?
We sure like to have a team approach, absolutely, to work with the patient's medical provider, to pull in psychiatry when we can if needed. and to all work together toward the better health of the patient.
Yeah, I think the team approach is preferred. There's just limitations in the number of psychiatrists, psychiatric nurse practitioners. So actually the vast majority of medications prescribed for depression and anxiety are prescribed by family doctors, primary care providers. But ideally, for most of the conditions we treat, a combination of prescription medications combined with psychotherapy has been shown in research to be more effective than either on its own.
And that's where you would come in, Katie. It would be that piece. And would you also then work with the patient and the family as a whole, say if in the event that it might be a child?
I would say the ideal when a child or adolescent is dealing with depression or anxiety, helping serve the whole system tends to be more effective than serving the individual, because kiddos don't exist in isolation. They have families that want to help, families that want to understand. And so as much as I can include the whole family in the process seems to have a better outcome.
And kids, that's such a unique piece. Will kids who are depressed when they're children, is there a cure, or is depression just something they will deal with the rest of their lives?
No, absolutely. I mean, I think, I don't necessarily think of it as a cure per se, but a lot of children will recover fully and may never deal with depression the remainder of their life. It really is kind of a case by case, but most people do get better. And if it does come back, oftentimes there can be years in between these episodes. We know that the more frequent someone has an episode, the more likely they are to have another episode. But certainly just because it's being diagnosed as a child doesn't mean this is something you'll be struggling with forever.
What's the tipping point for seeking that treatment? At what point does a parent say, I need to get help for my child?
So I think a lot of what comes up in mental health is what we call how we're functioning day to day. So our functional status. For adults, it's ability to kind of maintain those close relationships, go to work, do the things that we need to do day to day. For children, it's often, are they able to go to school? And when they do go to school, how do they function at school? So often one of the tipping points is when things at school start to get very rough, and maybe a teacher will say, you know, so-and-so is just, they don't seem the same, they're not doing as well as they used to. And parents know their children best. And oftentimes it just simply gets to the point of, you know, I feel I've reached kind of my limits and what I've able to do for my child, things that used to work might not be working any longer. And that tends to be when families reach out for help.
And what's that first move that a parent might make? Who do I call?
Yeah, so I think in today's world, one of the first moves people make is talk to their pediatrician or their family medicine doctor. And I think that's the best way to go because they're immediately available. You already have a relationship with them. Your child is likely comfortable with them. And they're able to connect with resources beyond their kind of scope of care if necessary. I think we're growing in the Spokane region in terms of providing child and adolescent psychiatry services. So a program like RISE is there to kind of help this type of family issue or individual issue. I usually say start with the providers you know best.
And adults will even hesitate to seek care. They think, I'm going to snap out of this. There's a stigma attached.
Unfortunately, yes.
And is there such thing as waiting too long?
Well, the big concern would be untreated depression progressing from a mild form through to a moderate form to a severe form, where when it gets more severe, people start really having a decline in their ability to function. Like when someone's mildly depressed, they can kind of trudge through and get to work, and they're still kind of taking care of things and paying the bills, and the kids are getting fed, and basically things are getting taken care of, but it's a challenge. Once you start getting into moderate and severe depression, it becomes more of an issue where people are sleeping 14 hours a night or getting only 3 hours a night, and they're just constantly tired. They're missing work. Maybe they're looking to alcohol or other substances to try and self-treat. Things start really falling apart, and then when people start developing suicidal thoughts, that's when things get really scary. And so waiting too long raises that concern that a person is going to get to a point where the suicidal thoughts are going to get strong enough that they're going to act on them and try to kill themselves.
Can it also start to lead to, other than maybe addictions to drugs or alcohol, other physical disabilities or conditions?
Well, the lack of self-care that comes as people get increasingly depressed can certainly make managing other medical conditions much more difficult. So people who have diabetes and are supposed to be taking insulin or blood sugar pills, watching their diet, getting exercise, a lot of times that stuff falls to the wayside, and now they're just taking their insulin once a day instead of 3 or 4 times a day. They're not getting out of the house, they're not getting the exercise they normally should get, and now their blood sugars are up in the 300, 400 range, or if they have type 1 diabetes, they're ending up in diabetic ketoacidosis and getting admitted to the hospital. Or if they have heart failure or other conditions, these things are decompensating, and then they're being admitted to the hospital not for the depression or suicidality, but for emergent management of these other medical conditions that have fallen apart.
Yeah. A spiral can be seen there. We have a phone call coming in from Jacqueline here in Spokane. Good evening, Jacqueline.
Hi.
Hi. You have a question for the panel?
Well, I was just curious. I know that the panel had talked and touched on about obviously anxiety and depression, but I was wondering on their thoughts of the comorbidity of the two. Like if one causes the other, do they just kind of tend to go together, or thoughts on that?
Mm-hmm. Katie, I think you did touch a little bit on that. Can you expand on it?
Well, I'm curious what other panel members think, but in some ways it can be a chicken and the egg kind of situation, in terms of if you're starting off with some anxiety, and say for a kiddo having some separation anxiety with his parents, which means he doesn't want to go to school and avoids going to school and tries to stay home as much as possible. By staying home and staying inside, he's getting more and more isolated, less and less engaged with the world, which then kind of that environment can almost be a breeding grounds for some depression. So starting with anxiety can fuel depression, and vice versa with depression. When our energy levels go down, when we're isolating from the world, when we aren't taking care of ourselves on a daily basis, our thought patterns can also get fixed in a negative fashion, which can then fuel some anxious thoughts of worrying about things, worst case scenario, catastrophizing can come up. So I see it as a chicken and the egg kind of situation.
And you see patients that will sort of have that same scenario?
Very much. And we tend to choose which one is more prominent right now, and we'll start by going in there and eventually likely get to the other as well.
Mm-hmm. What kind of therapies are available then for anxiety, separate from depression?
Well, the same kinds of therapies can address both issues. I think the most common or most empirically based therapies are the cognitive behavioral therapies and interpersonal therapies. And you can certainly address the negative thinking or the behavioral problems like not taking care of yourself that go along with depression, as well as with anxiety. You know, for example, someone with more of an anxiety might have trouble falling asleep because they're so wrapped up in their negative thinking. So there are some behaviors we might change with sleep patterns, as well as working with the thoughts of anxiety, just similar to the way we work with depression.
Yeah, go further into the cognitive therapy, basically using some of those techniques then to sort of, is it a diversion of sorts?
Sometimes we use distraction techniques, like, you know, if you find yourself not able to get out of your head, I talk about people being in a hamster wheel, you know, you can't stop thinking. Certainly helps to get up and go do something else, even if it's washing the dishes, you know, but that just helps for a little while, where changing the negative thinking process that you have, you know, I'm not a good person, or I'm never going to make it, or, you know, the kind of negative things that you learn over time, takes a little bit more work to learn how to recognize that and change that thought into something a little more positive or even neutral to help get you out of that rut.
And those interpersonal relationships, which have become more apparent as we become more addicted to our electronic devices and our phones, and we're losing some of that. And we're seeing kids with those conditions more and more as well.
Absolutely. I think the full effect of kind of constant attunement with electronics, social media, I think the full effect in terms of how it shapes children as they develop is yet to be determined. I think we're seeing a lot of effects already. But I think the dynamic of, you know, child and family has changed in some ways. It's child and their device, and I think it creates a lot of issues, and it's just something I think historically we've never encountered anything like it. So it's all new.
Mm-hmm. We have another phone call. This one from Vicki in Wilbur. Good evening, Vicki.
Hi. I have a question. Mine is kind of related to moving to a new area and finding that most of the places I have called don't accept my insurance. or the ones that do are not taking adult patients currently. Can you make any suggestions toward that?
Who would like to answer that?
There's usually a number on the back of your card. That's probably the number you're calling to get resources. And then you're calling those resources, I assume, and they're telling you they don't have any availability. Is that right?
I don't know if Vicky's still
there.
there.
Vicky.
But...
So if that's the case, coming back to your insurance company and going to maybe a complaint line or a customer line and letting them know what's going on to see if they will allow you to see a provider that's out of network so they can help expand the options of what you have, or alternatively going back to your medical provider and seeing if they can help find a referral source for you, because they should know who's in the area and have a little bit better information.
Probably not the first time you've heard that before, some frustration with finding a provider and just lack of resources.
I think it brings up a big issue that we're all very familiar with. Is it's not just here in our community, but nationally, that this is really, there's just not enough providers, and access to care is really a major issue. And I think that's going to be a systemic solution in terms of how we address that, because the demand is there.
You work with the residency program, so are we making any strides?
We are.
Yeah.
I mean, and I think one of the exciting things about Spokane is we're working very hard on actually having a child and adolescent psychiatry fellowship, which is people who've done adult psychiatry training and now are learning how to work with children and adolescents. And the hope is that by training them here in Spokane, when they're done training, they'll stay within the region and provide those critical services. But it's not just psychiatrists, it's therapists, social workers, all levels, all members of that care team. There is a real shortage.
I mean, we all know it takes a massive amount of effort and energy and trust to put yourself out there and say, I need help. And our field really wants to be able, with that first phone call, to say, we've got you. Here's an appointment. Let's get you set up for the care that you need. And it's frustrating for all of us that there's a dearth of services, which is why fighting for new programs and getting more availability so we can honor people taking that step. We're working on it.
Yeah, making strides. Do people have to wait quite often then for appointments down the line?
It's very difficult.
Yeah.
A lot of times from the discharging people from the hospital, we're sending them back to their family doctors for follow-up, even though sometimes we'd say this is a person on multiple psychiatric medications, it's a complicated patient. My preference would be for them to be seeing a psychiatrist or a psychiatric nurse practitioner, somebody who, when you go in, the whole appointment is going to be, we're focusing on your mental health and well-being. Nothing against the family doctors, but they've got to deal with everything. So high blood pressure, cholesterol, diabetes, and also your depression or also your bipolar or what have you. If you can have a 30-minute appointment with someone who's focusing on your mental health, that's just a huge advantage. And a lot of our patients, I think, would do better with that. The resources just aren't there. So I think the residency is expanding. Hopefully a new fellowship in child psychiatry comes online. There are more and more psychiatric nurse practitioners in the region, so I'd say that would be something to definitely look into. Not just be looking for a psychiatrist, but if you can get into a psychiatric nurse practitioner, that would be a fantastic alternative.
So something people should ask about?
Yeah, and I mean, the Google search, psychiatric nurse practitioner, and see what comes up, or ask your family doctor if they can refer you to someone. I'm not sure if there are more psychiatric nurse practitioners in Spokane or not. I think there are more in the Coeur d'Alene area than there are physician psychiatrists.
So a matter of some persistence then might need to come into play then.
Absolutely.
Yeah. All right, we have Alex here in Spokane. Good evening, Alex.
Good evening.
Do you have a question?
Well, I think you've kind of danced around a little bit. Of course, I'm a combat veteran, and a lot of veterans have PTS, but what a lot of people don't realize is post-traumatic stress is also endemic among first responders or really anybody that sees a traumatic event and doesn't get over shock after about 30 days, and it's a recurring nightmare. And so we've had examples of football players lately, Mark Rippon, and I just thought to say that we still consider mental problems to be something that you can overcome, that you can't talk about them. You can probably get treatment easier for a headache than you can for depression. So I just called to say that a lot of veterans have it, but it's not just veterans. It's first responders. There are grade school children in Oakland walking to school. They're being treated for it because they have to walk through gangland. So it's a lot more widespread than people admit, and we're still in the dark ages, I think, as far as publicly dealing with mental illness.
Thank you, Alex. He makes a good point.
He makes a very good point. I think we're living in an age where a lot of horrific and unsafe things are happening at any age, and there is an impact. There's a ripple effect on all of us, and I would absolutely agree with him that trauma, whether it is your own experience, whether you are serving and bearing witness to other suffering, or whether you are reading about it, hearing about it, it's going to bear an impact, and I would say it influences the incidence of depression and anxiety in our culture. Yes.
Betty Jean from Edmonton, good evening. Are you there, Betty Jean? Betty Jean, are you there from Edmonton? Betty
Yes.
Jean, hi. Sorry about that. Do you have a question?
I have a question about, I've been diagnosed with clinical depression, and I've experienced 2 episodes of it, being 20 years ago and 10 years ago. And so now I've been told that I need to be on antidepressants probably for the rest of my life. So I'd like to know their opinion of whether someone like myself has a chance of being able to get off of antidepressants.
Dr. Garrett?
In this situation, when a person's had an episode of major depressive disorder and then it's gone into remission and then a long stretch of stability and then it's come back a second time, the statistics on this occurring again a third time, roughly in the 2/3, 66% chance that if you were to get off your medications, this would come around again. So I would say it's definitely something to talk about with your doctor, hopefully psychiatrist or therapist, about this. It's something that could possibly be done, but you're looking at a fairly significant risk, 2 out of 3 chance that getting off the antidepressants, the major depressive disorder is going to recur.
Are there risks to staying on the antidepressants?
Most of the newer antidepressants, as long as you're on something that's been tolerable and you've been on it for, several months, they're, as far as we can tell, very safe long term. I mean, Prozac or fluoxetine was released in the early 90s, and so we've got, 25 years of data on that, and people tolerate it. I mean, this is not to say they're not without side effects, but usually side effects are going to happen from medications, things that are going to come on in the first couple of weeks to the first few months. And so if you've been on something for, say, 6 months or a year and everything's going fine, it'd be very unlikely that taking it long term is going to be a problem.
Okay. We did talk about the need for more care providers when it comes to mental health and to depression. And Spokane has a brand new program to treat teens and adults that are battling depression and anxiety. It's called the RISE program. We've already touched a little bit on it. It welcomed its first patients this past Monday and on the campus of Holy Family Hospital. That's where the new program is. And we got an early look at this innovative approach to providing intensive mental health services.
This ribbon cutting has been in the works for more than a year and a half. In February of 2017, planning got underway to bring intensive mental health treatment to Spokane in the form of outpatient therapy. It's called RISE, which stands for Resources, Insight, Support, and Empowerment. There are 2 wings. One serves adults and the other adolescents, 13 to 17. It's voluntary. Patients attend anywhere from a few weeks to a few months. Because it's day treatment, patients go home at night, keeping a routine.
They're able to participate in their community, maintain their relationships, maintain their connections, and then return the next morning to continue those intensive services.
Those services include family therapy as well as group and individual therapy. RISE teaches patients skills in medication management, self-care, and relapse prevention. Colby Peach is the practice manager for the program. She says RISE was created for people who are battling depression and anxiety.
They're just typical members of our community, and that's really the face of anxiety and depression now. It doesn't discriminate. Most of us struggle with it at some point in our lives.
Individuals who need more than an hour or 2 a week with a therapist, but don't need to be hospitalized. Along with intensive therapy, patients have access to yoga, art therapy. There's also time to just hang out. A balanced approach to mental health designed to give people who are struggling a lifeline.
When they come into this program, their life doesn't stop. Their life continues, but they're also able to receive those intensive services that they desperately need.
And Dr. Loraas, you are a part of this program.
Yes, I'm very excited to be part of the program. It's a wonderful program. I think it's going to serve the community well. You'll often hear what's called a partial hospital program or an intensive outpatient program. I think the way to kind of think about it and keep it straight is a day program. And what we found is that inpatient hospitalizations, in the modern era, they've been getting shorter and shorter in terms of the length of stay. And most people with anxiety and depression don't need to be in the hospital. But there are times when the symptoms and the functional impairment become so severe that routine outpatient care just isn't enough. And so having this day program is kind of a nice middle ground where people can come in, get intensive treatment, but then return to their lives in the evenings and on the weekends where they can implement the skills that they're learning in the program.
Can you sum up sort of a typical day?
Yeah, so it's about 6 to 7 hours. And I work with the adolescents, so I can speak to them. So the first part of the day is basically some schoolwork, just so they can stay on top of the schoolwork, because that's an important part of where they are in their lives. But then the day is broken up into groups. And it's really learning skills to how to manage these intense feelings of anxiety and depression. Also engage in what we call psychoeducation, where you're learning about what is depression, what is anxiety, which kind of normalizes the experience.
Well, it makes them a part of the process.
Exactly,
yeah.
Absolutely. I mean, really, the goal at the end of the day is to empower them and to kind of give them the tools to take control of the issues that are impacting their lives. And for cases where it's necessary, I'll work with the adolescent if medication is part of the equation. And then we like to bring family on board, because that's really a big part of the equation as well to getting better. So groups for most of the day, breaks throughout the day, and then home by late afternoon.
Is there any other model like this in Spokane?
There may be. I think there's a new one maybe in the Valley, but as far as I know, this is it. And regionally, this is it. I think the next one similar to this would probably be in the Seattle area.
Mm-hmm. And how do patients get in?
Yeah, so a couple different ways. Individuals can call the number. I'm sure it's available online. They can do what we call self-referral. Oftentimes people are referred from the hospital. Nowadays people end up presenting to the emergency department seeking treatment. And kind of the options there are, you don't necessarily meet criteria to be in the hospital. So the hope is that this program will be a good solution for that. And then being referred by your psychiatrist, your therapist, your family practice doctor, or your pediatrician are all options.
Okay. We have another phone call from Aaron here in Spokane. Hi, Aaron.
Hi.
Hi, you have a question?
Hopefully you can hear me.
We can.
Yeah. I don't want to call and be negative. I know you guys are doing a positive thing, but I've just had some negative experiences, at least with Medicaid and getting mental health treatment in Spokane, or the Spokane VHO. And it's more of the continuity of care, where you go from one facility to the next. This is for depression and anxiety, PTSD. I've been to a major hospital, ER in Spokane, where even the doctor told me we're not mental health triage, even though my therapist sent me there. They sent me to a local stabilization clinic, where after 3 days they told me it was my time to leave. I told them I was still suicidal, and they said, we send people out of here that are suicidal all the time. So my question is, even when I seek help, and it's hard to ask for help when you're going through, a crisis, stuff like that, I feel like I'm just disillusioned with the system, so I'm even more afraid to ask for help. And so my question is, what's the best way for me to approach getting good, sustainable, long-term help?
Aaron, thank you so much. We appreciate your call, an important one tonight, too. Kim, any advice for Aaron?
Well, your medical provider is always a great resource at the top of the list for where you can go for referrals. And I know a lot of places when lots of people call these days say that they're not taking new patients, or that there's a wait of a few weeks before you can get in, and I'm afraid there's not much we can do about that in the short term. But to be persistent with asking for help and being real vocal about what the help is that you need when you do finally get your appointment, whether it's at a mental health clinic or with your doctor.
You can hear the frustration. He's been bounced around.
I feel bad about it myself. It's heartbreaking to hear that people out there are asking for help and even afraid to ask for help because they don't think the help will be there. And that's why the addition of these new programs is so positive, because we do have a gap in care. I mean, Erin is right that, you know, seeing someone once a week consistently isn't always an option. In some clinics, they're too busy. They're not severe enough to be in the hospital for a long length of time. So this middle ground program is a real asset and need. And the more programs we get like that, the better.
Dr. Garrett, I saw you nodding.
This is a very difficult problem, and I think thinking about this as the mental health care system, I mean, these programs are, I mean, loosely connected. You know, there's a hospital inpatient program, and then when you leave, you're being referred out probably to a therapist that's not affiliated with that hospital. You're seeing a psychiatrist who's probably not affiliated with that hospital. People are hopefully communicating, but I think as the importance of addressing the mental health issues continues to be, you know, just hit on how important it is. Hospital systems, health care systems are going to hopefully be building out their own outpatient clinics, their own intensive outpatient programs. So this is not a solution for now. This is not something, sorry, I can't give the caller great advice on this, other than to just be empathetic with this. This is a very difficult situation for everyone. But hopefully they'll be building out resources that are going to be more appropriate to address the needs of the community. You know, potentially more inpatient beds, more partial hospitalization space, more psychiatrists, psychiatric nurse practitioners, therapists.
Where did we fall behind in this? Was it not taken seriously? Where did we end up with this gap?
I think that's the question we've been trying to answer, and I think it's a complicated one. I think part of it is the stigma. This is an issue we as a society kind of shy away from. There's stigma within the medical community, people who have had experience, you know, in medical school. We all do a psychiatry rotation. I think that's a big part of it. I think funding is a big issue. I say, you know, to the caller, we don't have an immediate solution. What I always tell people, if this is an issue you're passionate about, you need to let your legislature, your representative know that this is something that is a priority for you, because a lot of this comes down to what we're funding within our communities. And it just, again, it speaks to the systemic issue of a shortage of access, available providers, and really there's such a demand that the system itself is strained.
There's a lot of good caregivers out in the community. Speaking as a therapist, community mental health care, there's a lot of passionate people out there who are getting inundated with caseloads that burn them out. And then we have high turnover in these agencies where patients are coming to get help and want that support, and providers want to give that support, and they burn out. And so I think a huge issue is a systemic problem.
We have a question coming in on Facebook tonight. Facebook user asking, if someone that is depressed is abusing drugs, is there a risk of also becoming addicted to antidepressants? It's an interesting correlation.
So antidepressants specifically do not carry a risk of becoming
they're not addictive.
Not addictive, okay. Not dependent in the same way that we think of other drugs. That being said, your body does get used to them, and should there be a time when you need to stop or discontinue, it can take a process. So usually we can't just stop the next day and everything be fine. And I always say, if you're on medication, you're not liking it, and you want to stop, discuss first with the person prescribing it your intention of going off of it, because usually you can do it over a week or two, and it's a much more comfortable experience. But in terms of a substance that you become addicted to, no.
Okay, so they're not interconnected.
Well, people don't take antidepressants and then get a sense of like a rush of euphoria the way they would if they're, you know, getting drunk or abusing heroin or methamphetamine or what have you. And so that lack of euphoria really isn't reinforcing the way that drugs of abuse or alcohol would be. But I think it is a good point that sometimes people look at the tolerance that develops with an antidepressant. Like if you just stop cold turkey, you'll feel more anxious, you'll have sort of strange muscle sensations, and they'll say, well, this is an indication that I've become addicted, when really it's an indication of tolerance, but we wouldn't call that addiction in psychiatry. And I think it's just another good point that you would not want to stop medications cold turkey. If you want to get off your medications for whatever reason, whether it's I don't want to be taking these pills, or these medications have bad side effects, I'm sleeping all the time, or I feel like a zombie, or I can't sleep when I take them, talk to your doctor about it, because the goal of working with patients is not to put them on pills that make them feel horrible. The goal is to find medications that they can tolerate, feel okay with, and let them, function better and just do what they need to do with their lives. And so if you're having a problem with medications, I'd say talk
because there are options.
There are options, and so sometimes doses can be adjusted down, or there are other medications to switch to. And so it's not a simple question of I'm on it or I'm off it. There could be different adjustments made.
Mm-hmm. We're just now starting to see a change of the season. Before we know it, snow will fly. We have that whole seasonal affective disorder, which is people that are affected by the change in light and the longer, darker days, I guess. That's real, isn't it? Seasonal affective disorder? Is that a form of depression?
Real. It's, the actual diagnostic criteria are not as common as we might lead ourselves to believe. Almost everyone in Spokane thinks they have it, But I grew up in Minnesota, so you can get outside when it's 40 below. You can, being outside and being active really helps. Exercising, certainly being outside in the daytime is nicer when it's light, but I think part of what happens is we hole up inside and we isolate, like you were talking about earlier. We don't see our friends, we don't get active, and we all feel a little bit more down and mopey, sad.
Mm-hmm. Well, how important is that piece of diet and exercise? How much good can we do for ourselves by changing the way we eat or by exercising more? Can it help in our treatment of depression and anxiety?
Hugely important, yes. In terms of movement and nutrition and hydration, those have a huge impact on our mood. So whether one has depression and anxiety or not, taking those three things seriously, and especially choosing exercise and movement that you actually enjoy, packs way more of a wallop than picking an exercise that you can't stand. So making sure you're getting moving, fueling your body, hydrating your body is going to ward off whatever amounts of feeling down and sad or actually having clinical depression.
Mm-hmm. Yeah. When you sit down with a patient or a family during family therapy, is that one of the first things that you might address?
Oh yes. I actually made a very strong case once that baking is a solid form of exercise. If that's what you're into, it makes you move your body. So choose something that you enjoy.
Mm-hmm. What about foods? What about diet? Can we make some solid changes by changing the way we eat, eliminating sugar or anything like that?
Well, I think this speaks to, a myth we're slowly getting over within our culture, is that the mind and the brain is somehow separate from the rest of the body.
Right.
The brain is an organ like any other organ, except it's unbelievably complex. So since it's as much a part of our body as our heart, our lungs, our digestive system, a healthy diet can make a big difference. And so I say a healthy diet that you're following to maintain a healthy weight is a diet that's also going to help your mind. And so I think eliminating, not eliminating sugars altogether, but being mindful of what you eat will certainly have an impact on your mental health.
Okay. We have Karen here in Spokane with a question. Good evening, Karen, and thank you for waiting.
Hi, thank you very much for taking my call. I just wanted to tell Dr. Garrett that I met him at Spokane Frontier Behavioral Health for Senior Citizens, and you only see him for a minute when you first go in there, and I guess he was just working there for a short time. But what he did was said something to me after I saw him that has helped me through everything I'm going through. I'm 74. I live by myself. I've got post-traumatic stress, severe depression, and anxiety. But when I was seeing him, what he did was, after the other people that worked there at Frontier Behavioral Health left the room, he and I just spoke for a second, and I walked down the hallway to leave, and he called me back. This is going to make me cry, but he called me back and said, Karen, look, you're going to make it. It's going to be harder than you think it is, but you're going to make it. And just that man telling me that has helped me through the last 5 years, because a lot of bad things have happened to me. I live in a bad neighborhood, so people take advantage of me, things like that. But what that man said has kept me going all this time. And I just want to thank him for being who he is. I always wonder where he was, or if I could get in touch with him.
No, you're welcome. It's good to hear from you, Karen. Hang in there.
I am, and it has a lot. I'm hanging in here because of what you said to me that one day. So
awesome.
thank you.
It's good to hear. Thank you.
Well, that makes a difference on what you do every day, doesn't it?
Absolutely.
Yeah. Yeah, something so simple. How did you know what to say to her in that moment? Do you recall that moment?
Not specifically, yeah. I think it just, in this field, we end up being empathetic people, caring people, and so it becomes just the moment hits you and you know what to say.
Boy, very emotional. Thank you for your call, Karen. What do we need to do to make sure that people are addressing, I liked what you said about the body and the mind being connected and changing the way we think about mental health and depression and anxiety, taking the stigma off, making sure that it becomes more of the conversations that we have when we talk about our health and not sweeping it under the rug, and making sure that it comes to the forefront so we're taking care of the whole person.
I think it's a cultural shift for sure. I think those of us within mental health and medicine can do our part by not shying away from these topics and advocating for these issues. I think we're seeing a movement within primary care in this concept called collaborative care. We're actually embedding mental health professionals within the primary care clinic. That itself is reducing stigma. Patients find it much more kind of accessible and reassuring when the psychiatrist, the therapist, the social worker is in the same building, and you can go in and meet them face to face with their primary care doctor. And that in itself builds trust immediately. So I think just moving mental health out of its own silo into a typical medical clinic is a significant movement in itself. But I think, as a culture and society, it's about having these conversations that we don't necessarily want to have. And for those of us who are in the profession, having the bravery to take that challenge on.
Do you all see that, Kim?
Oh, yes, absolutely. And you're right that team approach to care benefits not only us as providers, because we can communicate better and all support the patient better with their goals, but the patient does feel a lot more comfortable, is more likely to follow through and take part in their treatment.
And when they understand that, well, I hate to say, they're not crazy, they have a condition, they're sick.
And
they need to be treated.
It's not as unusual as you would think, and your doctor recognizes it and has his friend down the hall who can help you and pulls them in, or my friend across town who can help you. Talking to your doctor is something that should happen as soon as you feel like you need to talk to your provider, not waiting till you have a certain set of symptoms necessarily. But if you're concerned, the worst thing that's going to happen is your provider's going to say, I think you're okay.
Yeah, I can imagine that takes a weight off of a little bit of a weight off for a patient.
It's never a waste of time to go talk to your provider, never.
I think one of the exciting things with collaborative care is we're starting to screen for these issues, annual visits or even routine visits, quick 10-question surveys that if the score is high enough, it kind of cues us that this may be someone who is suffering from depression and anxiety, and it allows you to kind of bring up the subject, which in itself could be a major relief for someone. They may not be feeling comfortable bringing it up themselves, but if a provider they trust says, the score is a little bit high, what's going on? I think that in itself has made a big difference as well.
And starting at a young age?
Absolutely. We're actually, within the psychiatry residency here in Spokane, we're actually working over the next few months rolling out this type of service for adolescents. So the hope is that in time it'll be a service that we can provide to pediatric clinics, so starting at a very young age.
So sort of having a mental health check just like you would your physical every year.
Absolutely, to incorporate it as that whole person care. And I think another component that was mentioned from one of our callers that's really important is for adults who are in some sort of caregiving field, be it a teacher, a doctor, a first responder, a therapist. We are not robots. We are also susceptible to depression and anxiety. And I think one great way to move the ball forward of normalizing this is for all of us to take our mental health seriously, especially if we're caring for others. We are likely to have some of those effects. And so taking care of ourselves as well as we'd want our patients to take care of themselves.
We have another Facebook question coming in, this one from Kathy. Are B vitamins helpful to treating depression? And that brings up the whole supplement piece here.
Well, it's an interesting question. There is a genetic condition where there's an abnormality in the processing of a certain type of B vitamin, and they've found that there's a certain supplement, a methylfolate, that does have evidence supporting its use in treating depression. That being said, I don't know about other research that provides like a ringing recommendation for just B vitamins in general. The B vitamins are water soluble, so if you take a B complex along with a multivitamin, it's pretty safe. So it's not something I would be concerned about.
You might want to add it then to. And what about, are there any other supplements that can be helpful?
There's some research on low vitamin D, which is a big issue, in the northern latitudes. So having your family doctor check for vitamin D level and supplementing if that's low. And then there are a list of non-prescription supplements that are oftentimes recommended if you're not interested in taking antidepressant medications like S-adenosylmethionine or St. John's wort, or there's a list of several. The difficulty with those is there's not really enough money to do research on those supplements, and so the research that's available is not very robust. So it's difficult to provide a strong recommendation to take those medications.
Well, and sometimes people will jump on the internet and do their own diagnosis. Dr. Google a little bit.
I would just be concerned too about, other medications people are on. So I would never tell a patient, try this or that over-the-counter natural thing, without checking
because there can be
your
interactions.
Provider.
You think, oh, it's a natural product. It doesn't interact.
It doesn't mean it doesn't affect you in some way.
Okay, something definitely to bring up with your care provider then. We have Andy in Spokane. Hi, Andy. Thank you for waiting.
Hi, thank you for taking my call. I recently read where they say that psychedelic drugs like LSD possibly create new pathways in the brain that could be helpful for mental illness. Could you address that for me?
Thank you, Andy.
So, it's a very interesting question, and for those of us in this field, some of us find this an exciting topic or a very scary topic. But most of the work right now that's been done is in patients with terminal cancer, so palliative care patients, and not necessarily LSD, but other psychedelics, using those in very controlled settings to help with kind of the anxiety that's associated with facing your own mortality. But the jury's kind of still out. I think it's an area of ongoing research. It's not necessarily a lot of research within the United States because of regulations issues, but within Europe, a lot of work is being done on kind of hallucinogens and psychedelics in terms of treating a variety of mental illnesses.
Interesting.
I think PTSD being one of these. I think the Veterans Administration is looking into this strongly from research I've seen.
Ketamine is up and coming within depression and then acute suicidal ideation. So there's been some early data that suggests that ketamine at very specific doses can actually reduce suicidal thoughts.
Okay. From what I've seen, this is not like giving a patient a month prescription for ketamine or a month prescription for LSD every day. It's more like going into a therapist's office who's been very specifically trained, taking this substance, and then going through very specific counseling with that therapist over the course of several hours, and then having a family member take you home.
Yeah, I would think it would have to be quite controlled and something when you're dealing with some of those psychedelic drugs especially. We have an email coming in from Jacqueline, and we've sort of touched on this, but let's talk about it again. She says there's a stigma with depression that you can just switch it off. Do you have any thoughts on how to change this stigma? Partly the conversation we're having right now, but
agreed.
Yeah. I think I like to describe things like depression and anxiety in two different ways. One is that they are less of a sprint and more of a marathon. This isn't a short burst and then it's over. This is a long, prolonged process that can come up again and again. And I also talk about them as coming in waves. So yes, there are periods of time where depression and anxiety can ease for a variety of reasons. However, if you've had, like has been said, if you've had a depressive episode, if you've had a period of anxiety, chances are it may come back again, depending on different triggers. And so shifting from I would say a black and white lens of depression and anxiety, either you have it or boom, you don't, it's a big vat of gray. It comes on a spectrum. It can ebb and flow.
And when you sit down with families, that must be something that has to be addressed, especially with people that don't understand that. And they think that one of the family members can just turn it off and on.
And there's really good intention behind that desire of, I hate seeing my loved ones suffer, and I so badly want this to be an easy fix. So please agree with me, Katie, that they can just turn it off, because then the person I love isn't hurting anymore. And so yes, that's something that I do a lot to inoculate the family, to help them prepare. There's going to be times where you celebrate, there's some easing of that pain, and I want you to be prepared to receive them again when the pain comes back up. So yes, that is a big part of the process with families.
Okay. We do want to remind you too this evening that if you do need immediate help for any reason with anxiety, depression, if you're having suicidal thoughts, you can always call First Call for Help. You see the number on your screen, and it is important that you take that step, that you reach out for help, especially if you're having any kind of thoughts about hurting yourself. We want to make sure that people have that phone number available if they're having any kind of tendencies toward that, because it can reach a point where somebody wants to hurt themselves and take their own life, and it they feel like there's no other way to go. Is that the case?
That's true. People get into dark places and they're not thinking in a rational way. Various stressors have built up, and from their perspective they look unsolvable. And sometimes there are a lot of stressors that are going to be very difficult to tackle, but the thing to remember is that with help and treatment, people do get better from their depression, and suicidal thoughts can go away.
And so important. I think we've stressed on it that you do need to reach out, you do need to ask for help, not to be embarrassed or allow that stigma to get in the way of your treatment and becoming better and whole and feeling healthier and just getting back to better health.
I think another thing about stigma, and usually it comes up when it's a patient saying, my dad or my husband or whoever just doesn't quite get it. Yeah. They don't, I'm really depressed, they tell me to just go exercise or just call my friends. And that's what works for someone who's just having a rough day. But when you're in the midst of a clinical depression, you can't just pull yourself out of it or think yourself out of it in an afternoon. Yeah. And so in the hospital over in Coeur d'Alene, we have a family education session for patients who have been admitted. And that tends to be very effective in explaining the ins and outs of depression, anxiety, other diagnoses to family members. I think I'd strongly encourage people, if they're having difficulties like that with family, to talk to their therapist and see if they can bring family into session to have the therapist meet with them. And then NAMI, the National Alliance for Mentally Ill, okay. I'm certain they've got resources for both patients and information for families.
All right. Well, the most important thing is to seek help. And thank you so much to all of you for being here tonight. It was a great discussion. And that's going to do it for this edition of Health Matters. And thanks to everyone who emailed and called as well. Be sure to join us on October 18th when our topic will be breast cancer. Until then, I'm Teresa Lukens. Good night.
Health Matters is made possible by our viewers, the friends of KSPS, and by Providence Healthcare.
I'm Arnie Peterson, and I'm an orthopedic surgeon, and I work at Sacred Heart for Providence Medical Group. When I needed my hip replaced, I chose Providence because of the professionalism and the care that I knew I'd receive. I never thought twice about going anywhere else.
My name is Beth Perez, and I am a registered nurse, and I work at Holy Family Hospital on the labor and delivery unit. I'm about to have my second child, and I chose Providence because I love and trust the people that I work with, and why wouldn't I seek care from people that I love and trust?